Welcome to DHEC's March 5th media briefing on COVID-19 in South Carolina. I'm Christy Moore, DHEC Chief Communications Officer, and I'll be facilitating today's briefing with Nick Davidson, Senior Deputy for Public Health, and Dr. Jane Kelly, Assistant State Epidemiologist. First, Nick Davidson will give an update, followed by a segment of questions. Before we begin, I'd like to remind everyone to please remain on mute so that we can get a good quality recording. Nick, I'll turn it over to you for today's update.
Great, thanks. And Christy, is the audio okay? I know I was having problems earlier.
It's good.
Okay, great, thanks. Well, good afternoon, everyone. 1 year ago today, March 5th, 2020, was a historic day, even though we didn't know it at the time. March 5th, 2020 was the last day where we would ever say there are no cases of novel coronavirus COVID-19 in South Carolina. And so unfortunately, that next day, March 6th, we announced the first 2 suspected cases of COVID-19 in South Carolina. It's been an entirely unprecedented year, I think, since then, as we all know. We could all talk probably for a long time about everything that's transpired, not just in this state, but certainly across the country and across the world for the past year. There are 2 significant accomplishments, though, I would like to highlight as we look back on where we've been. A year ago, vaccines that protect us against this deadly virus didn't even exist. And yet today, more than 1 million doses of life-saving vaccine has been given to South Carolinians. And that's more than 82 million doses across the country. So that truly is an astounding feat. We owe it to our scientists, to our physicians, our medical experts, dedicated staff in the field, so many people who dedicate their lives to developing vaccines that save our lives. And also, we owe great thanks to those who are making those vaccines and those vials and those syringes and those other materials needed to safely administer the vaccine. It's absolutely an incredible undertaking. In South Carolina, I'm happy to share that now, a year later, there are more than 900 provider locations who are being given vaccine. If you look at our vaccine locator map, you can just see how many green dots that there are. And those green dots represent locations who are currently able to schedule your vaccine appointment. Today alone, we've added an additional 72 CVS locations, and many of which are offering the single-dose Jansen vaccine. Today, for instance, at the Darlington Speedway, there's over 4,000 appointments that have been made by people to get their COVID-19 vaccines. That is an incredible success. And as more vaccine becomes available, there will be even more of these large-scale events across the state. A second note I want to reflect on is our state's long-term care facilities. As you know, or as I guess you'll remember, when the virus first began to spread across the country, nursing homes and similar facilities were quickly being devastated by the virus as it took its toll on nursing home residents and those who are most susceptible to COVID-19. In South Carolina, we had been working with our state's long-term care facilities since before the first cases in our state to help them prepare and implement the CDC recommendations that were current at that time. In April, DHEC announced we would be providing testing to every long-term care facility resident and worker in the state, and that massive effort rolled out across several weeks in May. And now, 1 year later, we're able to say that nearly every long-term care facility resident and worker in the state has had the opportunity to be vaccinated against this deadly virus. I'm going to go into a few numbers related to our efforts there, but certainly as of today, make sure I got the right numbers here. Yep, 59,536 long-term care facility residents, as well as 36,346 staff members have completed their vaccinations. Of our skilled nursing facilities, 100% of the 193 skilled nursing facilities have had their first clinics, and 86%, that's 166 of the 193, have had their second clinics completed, and 52% of those facilities have had their third and final clinics completed, with many more clinics scheduled to be able to finish all of those facilities. For our community residential care facilities, those which folks often refer to as assisted living homes or facilities, 98% of our state's CRCFs, the assisted living facilities, have completed their first clinics. That's 485 of 495 facilities. 85% have completed their second clinics. That's 423 of the 495 facilities that have completed second clinics. And 19% have completed their third clinics. And certainly there are many more that are scheduled as well. So incredible efforts have been taken by so many people to protect our loved ones at these congregate living facilities. I myself have relatives in them, and I have no doubt that these efforts have saved lives. I do want to thank our private partners, at CVS and Walgreens in particular, as well as a few independent pharmacies who have been the ones conducting these clinics. We are so appreciative of their efforts. It's taken massive amounts of time, many days, and staff across the state to make that happen, and an awful lot of coordination with our facilities themselves, and we appreciate that coordination by the facilities and with those facilities. As our state advances into phase 1B of our vaccination plan on Monday, I want to remind everybody how crucial it is to make your appointment to get your shot or shots. You do need to provide let me be really clear about that. You do not need to provide documentation as to your medical conditions or your risk at work in order to receive your shots as part of phase 1B. The vaccination is here. It is limited, but it's available. So please do not wait. If you're eligible for phase 1B, visit the vaccine or the Vax locator map, as we call it. Call or contact one of those providers, and please make your appointments. Vaccines are how we will win this fight once and for all. Thank you.
And thank you, Nick. At this time, we're going to turn our attention to answering some questions that we received. And the first question is actually for Dr. Kelly. Can you provide a list of the developmental or other severe high-risk disabilities that are eligible qualifications?
It's not possible to provide a complete list of the developmental or other disabilities that might place an individual at increased risk for severe COVID-19. I mean, some of these disabilities represent really rare congenital conditions, for example. But I'd like to turn that question around a little bit. Not all disabilities confer increased risk for severe disease. For example, being blind is a disability, but it would not confer increased risk for severe COVID-19. So, I think as we think about disability, we're thinking about a broad array of conditions. I also want to make the point that disability that increases contact with people, for example, with more caregivers, again, doesn't increase severe disease. It maybe increases exposure to SARS-CoV-2, but not necessarily severe disease. And therefore, not all people with disabilities are eligible for phase 1B.
Thank you, Dr. Kelly. Nick, is there a list of all frontline essential workers that are eligible? I think the list on the DHEC site with the et cetera is confusing people.
Sure. And another point to really provide some good clarity, 1B is not based on job categories. It's based on risk. So if people are in person at their place of work and they indicate that they have frequent, close, and ongoing contact with others in the workplace, that qualifies them for 1B. We placed examples on our website and in some of our guidance just in an attempt to indicate that various professions would likely have individuals who would indicate they are at high risk. We certainly had received questions from a number of providers, so we just thought a good idea to give examples of industries where individuals would likely indicate they are at high risk. The concept of Frontline is truly just an attempt, as some other states have done as well, to indicate that those individuals are in person physically at their place of work and not, say, working from home.
Okay. Dr. Kelly, this is a great question. Are the underlying health conditions DHEC has online the only ones that make people eligible for phase 1B?
So The list that we have for phase 1B for medical conditions that place an individual at increased risk of severe disease is taken largely from the CDC list, for which there is strong evidence that those conditions cause increased risk. It's on the CDC webpage, and our phase 1B description has a link to that page. Those conditions include such things as cancer, not a history of cancer, but current cancer, diabetes, heart disease, and a number of other conditions. Again, I would stress that this is based on the science of what we know. So there may be some other medical conditions that have not yet been identified in studies at placing a person at increased risk, but might be identified in the future. So we always have to remain flexible that there might be new evidence that emerges about a medical condition. And if that occurs, we would add that to our list of medical conditions.
And what prevalence are we seeing in South Carolina of the most common variants?
Right now, we know that we have 30 cases of the South African variant and 10 cases of the British variant, the B.1.1.7 variant. Of course, there may be more cases than that we know of, because this depends upon testing for these variants. And as far as we know, they have not become the dominant variants. It is still the wild type variant that is the predominant one in South Carolina.
And do you know how much sampling is DHEC doing to detect the variant? And then secondly, Dr. Kelly, how does DHEC's current rate of sampling to detect variants compare to the rate of sampling that would be considered ideal by scientific standards?
Sure. Well, let me go back a step and just point out that for those who are really interested in the numbers, we do have a variance dashboard on our DHEC website. So just like you can look up other statistics, other data around SARS-CoV-2, you can also look at this variance dashboard. It's updated every Friday to see the number of variants. But in terms of, what is DHEC doing to detect the variants? How much surveillance do you need to do? I don't know that anyone has exact numbers to answer that question. Certainly, we are stepping up our genomic sequencing, as is CDC, as are other states in the country, to try and detect these variants. But before people get too overly concerned about needing to know the exact numbers of variants, I'd like to point out that the public health measures and the clinical measures of taking care of people with variants are the same as with wild type. The public health measures of preventing transmission around wear your masks, maintain your distance, wash your hands, avoid crowded indoor settings. It's the same for these new variants as it has been all along. Ditto for medical treatments with remdesivir or dexamethasone or some of the other medications. The treatments are the same. So we want to do surveillance around these new variants so that we know trends for the future, but it is not important to know the exact number. It's not important from a public health or a medical care point of view to do this sequencing on every single case across South Carolina.
And how long does final authorization typically take for new vaccines? What's the best estimate on when the current vaccines could receive final authorization?
Okay, so a couple of terms here, authorization and approval. So the vaccines, the 3 vaccines that are currently available in South Carolina are all available under an emergency use authorization. FDA does that when they weigh the risks and benefits of authorizing something to be used before it is fully approved. Now, what does that mean? That means that they still have to go through all the rigorous testing to prove efficacy and to demonstrate safety. And then they gather 2 months worth of safety data to present it to FDA. For a full approval, one needs at least 6 months of safety data after people have completed their second dose of vaccine. And so the companies, Pfizer and Moderna, that may approach having that sort of information available on tens of thousands of people, they will apply for that authorization. The FDA made a decision that if we waited those additional 4 months for full authorization, think about the number of people who would have died in the interval or who would have suffered severe disease. So yes, these vaccines are available right now under this emergency use authorization. That will not remain true for forever. They will all apply for the full FDA authorization. The difference really is the amount of time of safety data being gathered. Most vaccine adverse reactions are going to occur within the first 6 to 8 weeks of post-vaccination. So that's why they receive that authorization. And I'm sorry, the second question was, what's the best estimate?
Yep.
So I think they're gathering their data to present to FDA right now for that authorization. So I would imagine we would see that authorization in the next few months, but I don't have that insider view at FDA or at those companies to know an exact answer to that question.
What is the best estimate right now of when we will know if an annual vaccination will be recommended for COVID-19?
I wish I had a crystal ball to answer that question. This is a new virus, new vaccines. It's going to take some time for all of that to play out, but here are some things to think about. What we know right now is all 3 of these vaccines, it looks like they have, they maintain high levels of antibodies for months after administration. Now, of course, normally your antibodies after a vaccine are going to decrease with time. You don't want to continue making a protein unnecessarily. But there's good evidence that all 3 of these vaccines have long-standing immunity. The question is what's going to happen with these variants. Perhaps we will need in the future to tweak these vaccines to cover the new variants better. So it's possible, just like with influenza, that this might be that you need an annual booster, that the vaccine's a little bit different every year. It's too soon to tell.
Thank you, Dr. Kelly. You're going to get a one-question break. Nick, has DHEC made any decisions about whether to expand use of the state system to schedule vaccination appointments and/or to use the system to replace vans? And if not, when is that decision expected?
Sure. As you probably know, DHEC has already been using CVAS in order to schedule appointments for any of our clinic events. We have also now decided that we are going to offer CVAS to other providers who don't have a current appointment scheduler and want to use it. There are some providers who use VAMs to schedule, and some of them have expressed various concerns over time with it or find it difficult to use. There are some entities who may prefer to use CVAS over their own electronic health record scheduling system that we have, but we are going to now begin to offer that to others. You might have noticed that for the events in the PD region, the one today at Darlington and the 2 for the past couple days, the large events, about 2,500 vaccines per event, I think, taking place in the Myrtle Beach area, use CVAS to schedule those. And that seems to have worked very, very well, and the providers seems to have enjoyed using it and thought it to be productive. So we are going to continue to monitor upgrades and updates that are made to VAMs. And if we find that it at some point in time is a better option, then we will look to make sure that people can use that if they choose as well. But we will be continuing to improve CVAS ourselves, and we also, like I said, will be beginning to offer that out to providers to use to provide a one-stop shop. It's a very simple way to do the scheduling, and within our DHEC clinic events, we've really benefited, as have clients benefited from the ease of use.
Perfect. Dr. Kelly, how many people in South Carolina have tested positive for COVID-19 after receiving the second dose of the COVID-19 vaccine? And if this figure is not being tracked, why not?
I personally don't have that exact number. I know that we are definitely following up on that. When we have people who are fully vaccinated, meaning people who have received their second dose of vaccine, and it's at least 2 weeks after that point, and yet they get a breakthrough case of COVID-19. We are definitely following that to try and understand what are the determinants of that, both that individual's immune system or biology, what do we know about that individual, but also what do we know about the strain that they may have experienced. So that the viral the molecular test goes to CDC so that CDC can do some genome sequencing to determine if this is a new variant or what is going on with that. But I don't have the exact number of those cases. It's a small number, but there are a certain number of those cases.
And can people who have been fully vaccinated still transmit COVID-19 to people who have not been vaccinated?
That's a very important question. So let's think about how were these vaccines tested. They were all tested to see if they detected if people experienced symptomatic disease. When we say Pfizer, Moderna, 95% efficacy for preventing symptomatic disease, that doesn't tell us anything about whether it prevents asymptomatic disease. So it is possible for a person to be fully vaccinated, be exposed to SARS-CoV-2, contract the infection, have no symptoms, not know that they're infected, and yet still be contagious. I don't mean for forever, but be contagious during that 10-day period. That's why even after vaccination, we ask people to continue to mask, distance, wash hands, avoid crowded indoor settings, because it's possible that they would get asymptomatic infection and transmit it to others. Now, does that mean we're going to have to mask forever? No. Once we reach a point where enough people are vaccinated that we don't have this concern, that's when we can let up on some of these mitigation measures. But still, right now, it is all important to avoid transmitting when you're asymptomatic, that even after you're fully vaccinated, please wear a mask, keep your distance, wash your hands, avoid crowded indoor settings.
And have the vaccines shown different levels of effectiveness to different strains of the vaccine?
That's a little bit of a tricky question to answer because it's complicated. So for example, Pfizer and Moderna vaccines, they were tested at a time where we didn't have these circulating variants. So they were tested against what we call the wild type. Whereas the Johnson & Johnson or Jansen vaccine is tested at a time and in countries where there were variants circulated. For example, it was tested in South Africa, where 96% of people infected were infected with the B.1.351 or South African variant. So you can't compare these vaccines head to head in a fair way because they were tested in different ways against different variants. But let me say a little bit more. All three of these vaccines are highly effective against variants when we're talking about severe disease, hospitalization, and death. And that includes the South African variant. Johnson & Johnson was 85% efficacious against severe disease, including in South Africa, where they had no hospitalizations, no deaths among people who were vaccinated.
Perfect. DHEC data, this is going to be for Nick. DHEC data shows some rural counties have available vaccine appointments, but some residents are choosing not to take advantage. What role, if any, will local demand for the vaccine play in the region-based distribution plan that will be presented to DHEC's board?
I think we can probably all imagine that some of the anecdotes that we've heard recently about some, particularly maybe smaller rural areas, not having, choosing not to take advantage, maybe not having demand. I think I can be pretty certain that the demand will increase greatly and probably already has starting Monday with 1B. So I think for some period of time that will probably be less of a worry. I think that greatly increases the number of people who are likely to be eligible. So I think in the long run, though, when we look at our regional allocation model, it is legislated that we must distribute regionally on a per capita basis. So as a large, 4 regions within the state, the region will get what the region deserves from a per capita base on a per capita basis. However, we certainly won't continue to send vaccine to providers within those areas who just don't have the demand for it. And so we'll work closely with providers as time goes along because at some point, I think we can all hope and we expect, obviously, that there will eventually be more supply than there is demand. So we will do that distribution in a smart way while still conforming to that which the legislature set forth for us.
Okay, and that's a perfect lead into the next question. In your view, would the county-based distribution plan that was presented in February or the region-based distribution plan result in higher vaccination rates for rural communities?
Sure. That regional model gives us the flexibility, as I think I was alluding to a moment ago, probably, that if we see areas of great need in a community or areas where the need is less, allows us to be able to use the vaccine where it's needed. So there's not a sort of a single distribution plan that's more effective than others. This regional model will get vaccine to all parts of the state, particularly given that we will have a baseline allocation going to all providers, assuming that they have need for that vaccine. And so the regional model really encompasses that which the county-based model was envisioning, and still gives us the flexibility to get vaccines to special populations or underserved communities, and wherever it can be used and used quickly.
Thanks, Nick. Dr. Kelly, this next question is for you, and you'll need to unmute. So what can people do to fight COVID fatigue?
I know that there's a great deal of COVID fatigue out there, but think about how far we have come in a year. We don't want to let up the pressure now. We have renewed hope with the arrival of vaccine that we can defeat this deadly virus. But especially with new variants that may be more transmissible circulating, we don't want to let the pressure off now. We don't want to let our guard down. So the message is still to continue with keeping on with a mask, washing hands, testing frequently, certainly testing if you have symptoms, but also consider asymptomatic testing because we do have virus circulating, keeping your distance, avoiding indoor settings, and getting vaccinated when it's your turn. We've got highly effective vaccines available.
Nick, now that shift workers can get vaccinated, does DHEC plan to expand mass clinic events to hours beyond the normal 9 to 5 in order to accommodate them?
Those we're definitely going to be looking to probably continually change the way and for whom and when and where we offer vaccine. Most of those, the word that was used in the question, I think, was mass events or mass clinic events. And so those are ones typically that DHEC would not likely be doing alone. We would be doing with partners. And so most mass events are usually a collection of individuals coming together and using the vaccine that collectively they have to be able to vaccinate a large number of people. So we and I think all of our providers do absolutely need to look at the groups or the individuals that we are now vaccinating and what their needs might be to try to accommodate them. And it doesn't just mean after hours, right? I think we also need to make sure it's Saturdays and Sundays, and we've been offering those all along, but those are probably going to increase, I would assume.
And does DHEC know how many Jansen vaccines will be allocated to the state next week, or when will you find out?
We do know that, actually. The vaccines coming to the state in the Jansen supply will be 41,100 for this coming week. Those are being allocated to the independent pharmacies because we want to try to have a broad geographic reach around the state. And they're both in some very rural communities and in some of our larger urban areas as well. So those will be coming through those means. We've also learned too, though, that our federal pharmacy partners, who has been recently CVS and now just starting this past week Walgreens, in other words, they're receiving separate allocations from the feds. from the federal pot of vaccine. They will also be offering Jansen vaccine, not at every location, but certainly trying to spread it among their locations. So I'm going to round there because I don't have the exact number, but it's approximately an additional 12,000 Jansen vaccines. And I think CVS is receiving more of those than Walgreens, if I'm not mistaken. It's about 8,000 and 4,000, or again, if you need the exact numbers, we can get you those. Again, 41,100 coming through the DHEC supply, and about 12,000 coming through the federal supply to the CVS and Walgreens.
And does registration for Phase 1B start at midnight on Sunday or a specific time Monday morning?
It starts as soon as Monday starts. In other words, it starts at 12 a.m. Or 12:01, I don't know which, Monday morning, bright and early.
And what alterations, if any, have taken place to prepare for this phase opening based upon how the opening of Phase 1A went?
Right. We did learn, I think, from 1A that it was quite effective, and so we're trying to replicate that. And what I mean is the allowing individuals to have a heads up prior to going to the next phase. And so we've given almost a week, 6 days at least, to allow that transition to occur. That gives providers enough time to change the messaging, for instance, in their online portals, that maybe their phone lines or their operators who are answering the calls are using. So it gives them time. It also gives our residents time. So if there are others who still want an appointment that haven't been able to get an appointment, it gives them a little bit of extra time when there are fewer people trying to make that appointment. So it gives both our providers and our residents, patients, a little bit of additional time to prepare. So I think that's probably the biggest thing. It's the two rollouts, frankly, as far as logistics go, are quite similar. 1A seems to have worked pretty well. We're trying to replicate as much as we can within 1B.
Okay. Dr. Kelly, can you confirm that Moderna and Pfizer vaccine contain polyethylene glycol, and some people are allergic to it? Should they seek the Janssen vaccine?
So yes, it is true that both Pfizer and Moderna contain polyethylene glycol. Polyethylene glycol is a common ingredient, for example, in over-the-counter laxatives. So I know that's a chemical name, but it's a common ingredient in many things. So some people will know that they are allergic to polyethylene glycol. The Johnson & Johnson vaccine does not have polyethylene glycol, but it has another compound that may be related, and that's polysorbate 80. Polysorbate 80 is found, again, in many common foods. It's in ice cream, it's in some salad dressings. So again, individuals may already know that they are allergic. If someone is allergic to polyethylene glycol, Johnson & Johnson might be a good choice, but we would recommend that they consult with their clinician, their physician, or if they have an allergist, to discuss it with their allergist.
Thank you, Dr. Kelly. Nick, based on the passage of House Bill 3707, has the regional distribution of doses began, and can you give details on that process?
Sure. And again, I mentioned it a little bit earlier, but let me go into a bit more detail. So yes, House Bill 3707 had two components, two primary components to it that were required of the department. One component was the vaccine allocation component. In other words, we must distribute regionally. And the other is a significant data component. And so our progress on those two are the following. The legislation effectively goes into effect today. And so the orders for this week already had to be placed. And so those orders which get delivered next week will not follow the regional distribution strategy because they were already placed prior to the effective date of the legislation. However, the orders that are placed next week will follow that regional distribution process, with additionally, as we've been asked by many providers, to give them a weekly baseline amount. So in other words, a base amount that they can expect every week. It might go up, but what we're saying is that it won't unless extraordinary circumstances dictate go down. So that is the allocation process that will begin with the orders placed next week for delivery the week after. The second, sorry.
Go ahead. I'm sorry, Nick. Go ahead.
That's okay. I was just going to say the second component of that is a data sharing initiative, and it requires that providers report to us daily for a subset of data elements. And so those data elements, we've created a portal into which providers will report those data elements. And then on a daily basis, we will report them out. That will also start next week. That portal goes into effect, or the providers begin getting trained on that Monday and Tuesday. They'll start reporting into it for data on Wednesday that will be reported out starting next Friday.
Nick, will the new Johnson & Johnson vaccine, with the new Johnson & Johnson vaccine, Georgia is prioritizing the first doses to go to teachers. Is South Carolina doing anything similar?
Sure. And just from a terminology standpoint, you're probably going to hear us for the most part refer to it as the Jansen vaccine. Certainly Jansen is a subsidiary of Johnson & Johnson, so it's just a bit more specific, and it's shorter, frankly. So you'll hear us referring to it as Jansen, and me throughout these questions or any others as well. So indeed, with the Jansen vaccine, or with any of the vaccines, teachers absolutely qualify as long as, they qualify. The federal guidance recently has made that very clear. Furthermore, the federal pharmacy partners have been asked to prioritize those teachers. And so we want to make sure that everybody, though, has access to Jansen. So we are not targeting Jansen towards any particular group. We believe choice is really important to South Carolinians. And so we are spreading that as far and wide as we can through, like I said, those 124 providers who are independent pharmacies, and then many CVS and now Walgreens locations around the state. So we're most interested in providing choice to South Carolinians and spreading it geographically so that people can easily exercise that choice.
Perfect. We're now going to open it up for live questions. Reporters, if you can please raise your hand, and when I call on you, I do ask that you only ask one question. Chris Joseph, you've got a question?
Yep. Hi, Nick. Thanks for the time. So in terms of this regional-based model, is your expectation that the consequences of it will mirror kind of that county model you talked about last month, where rural counties stand to benefit?
Right. Yes, I do believe that will be the case pretty clearly.
Caitlin, you've got a question?
Yeah, yesterday we heard from the South Carolina Department of Education that there could be some delay for school districts setting up their own vaccination plans for their teachers, especially in the coastal region, just because of how many retirees are located in this area. Do you guys have any comment on that, or any insight on, what's happening with that at this point?
I think I didn't quite. Can you repeat maybe the first part of the question?
Yeah, sorry about that. Yesterday we had heard from the South Carolina Department of Education that for school districts and their process to set up their own vaccination plans for their employees, that that there may be some delay because of how many retirees are located in the coastal region, that there seems to be a bottleneck for those appointments and for the vaccine supply that is available in the coastal region. And I was just wondering if you guys had any insight on what's happening with that.
I don't know the specifics. I hadn't actually heard that myself. I can definitely say, though, that the plans that each of the districts had put in place, I think, are going to be really integral to the success. I also know that the federal pharmacy partners that exist have been asked to prioritize teachers. And so I think definitely those districts continuing to work the plans that they have, but also if they haven't already, working with those federal pharmacy partners, which are CVS and Walgreens, to see what arrangements they can make could be helpful.
Jenna, you've got a question?
Hey, thank you guys for your time today. Really appreciate it. Earlier in the meeting, you talked a little bit about nursing homes and just, talking about some numbers and things like that as far as the vaccination. I also just wanted to ask, nationwide, we're seeing cases and death numbers going down dramatically since December. So is that the same case here in South Carolina?
Dr. Kelly, any insight you can provide on
I
case numbers in general?
I don't know the precise numbers off the top of my head, but yes, definitely we are seeing a decrease in not only number of cases, but hospitalizations and deaths. And that does in part reflect the number of vaccine doses that have gone to nursing home residents and staff. That information would be available on our DHEC website, so that should be easy to consult with. Sorry that I don't know the exact numbers offhand.
Judy, you've got a question? Judy, do you have a question? I think we're having audio issues again, unfortunately.
I will add to Nick Davidson's comments around coastal and challenges for teachers getting vaccinated. I think that might be a theoretical concern, but I personally know 2 teachers who just emailed me a couple of minutes ago saying, yay, we're set and we already have an appointment for Wednesday. So they are managing to find appointments.
Thank you, Dr. Kelly. Judy, do you have a question? I think we're still having audio issues. Does anyone else on the line have a question?
I might as well ask one. This is Nick with WPDE in Myrtle Beach. How are you guys?
Good.
Hey, my question was about the Jansen one earlier that Nick had answered. So I just wanted to clarify, Mr. Davidson, that this not getting there's not going to be a drop in the size of the shipment this week to next week. Is that correct? It's remaining next week.
No, that's a great follow-up question, and I think in previous briefings I had alluded to the fact that there would be a significant decrease, and we don't, after this week of 41,100 that's literally in the process of shipping now, that we would have a decrease, and that's indeed the case. Jansen had a group of vaccines, a number of vaccines that they had stockpiled that they're sending out, and that's this 41,100 in South Carolina. But weeks 2 and 3, I don't believe we're going to be able to order any Jansen in week 2. And week 3 is still a little up in the air. I believe it will be none that week also, but there may be a small amount, after which we expect to see increases. So, but that's not a surprise to us. We had been told earlier, or even late last week, to anticipate that there would be a drop in weeks 2 and 3. So it's just, it's based on supply and the flow of the supply out of the facility.
Judy, do you want to try your question again?
Yes, can you guys hear me now?
Yes.
I apologize. Okay, great. I'm so sorry. I'm not sure what my technical issues are, but we'll try and work them out. Just quickly, I'm trying to clarify some information or questions that I'm getting from a lot of teachers who are trying to understand the discrepancy between the CDC rating of disease spread versus DHEC's rating. Specifically looking at Richland County and Columbia, the CDC says the CDC is still rating us high, but DHEC is rating us low. What's the best way to understand that discrepancy and why it exists?
Judy, are you referring to case positivity rates?
Well, I think I'm referring to disease spread. Basically, the CDC is saying any area with 99, I think, cases over the last 7 days would be considered high. So are we talking the same language, Nick?
No, we're not. Well, I mean,
Okay.
Certainly one relates to another, but it sounds like you're not asking about percent positivity. And so,
No. I think I'm asking about disease spread, not percent positivity. Right.
Yeah, I understand that. And I haven't been comparing those two numbers recently. Unless Dr. Kelly has, we might have to get back to you on that information.
Yeah, I can't say that I've looked at those numbers exactly, but there are multiple measures that can be taken into consideration. Number of cases is one of them. Percent positivity is another one of them. And so, yeah, I think in South Carolina, we're looking at several different parameters in terms of recommendations regarding school reopening. And you may be referring to one parameter put out by CDC that says high risk versus when we say low or medium risk, but we may need to get back to you on that.
Thank you.
We are out of time. We do plan to hold an additional 2 45-minute briefings next week. That's going to be on Wednesday and Friday. If you do have any follow-up questions, please send them to our COVID Joint Information Center and we'll work to get them answered for you. I would like to thank everyone for your time today and your dedication to share the latest information about COVID-19 and our state's vaccine rollout with our fellow South Carolinians. This concludes today's briefing. Thank you all.